That's the schematic representation of the autonomic nervous system. If you see right from above to below, the entire ANS is depicted here as a schematic representation, wherein you have the parasympathetic nerves, the sympathetic nerves there, supplying the eye, the lacrimal gland, the submandibular glands, the heart, the lungs, the stomach, the intestines, the kidney, and the colon. So that's the way they control the involuntary functions of all these organs throughout the entire body. The sympathetic nervous system, also known as the thoracolumbar outflow, because it comes from the T1 to the L2 of the spinal cord, these are medulated preganglionic fibers and they arise from the lateral sympathetic column of the spinal cord. They come out through the ventral rami, as we have seen in the anatomy days, then where they become connected to the ganglia of the sympathetic chain, and the preganglionic fibers relay either in the lateral ganglia, which is the sympathetic chain, or the collateral ganglia, which is the celiac ganglion, for example. The non-medulated postganglionic fibers run for some distance before they reach the target organ of supply. So that in a schematic representation is what I just said. You have the sympathetic division of the ANA, and which goes to the preganglionic neurons. They form the ganglia there. The ganglionic neurons from the sympathetic chain, the collateral ganglia, and the adrenal medullae, for example, and they go on to the target organs, which supply either a visceral effectors in a thoracoabdominal cavity, thoracic cavity, and organ systems throughout the entire human body. The preganglionic fibers, after reaching the sympathetic trunk, may terminate in the ganglia, or it may pass upward and terminate in some other ganglia, or it may pass downward and terminate in the lower down ganglia. It may leave the sympathetic trunk altogether without synapsing and terminate in other ganglia which lie completely out of the sympathetic trunk. One preganglionic fiber synapses, mind you, by several postganglionic neurons. So it's like a electrical junction, single wire coming in and multiple wires coming out of the junction box. The important groups of sympathetic ganglia include sympathetic trunk, which is the paravertebral ganglia, prevertebral ganglia, and the peripheral ganglia as well. That's again a schematic representation of what I just said, wherein you have the postganglionic neuron there, the dorsal root there, and the preganglionic axon coming into the ganglia, coming out on the other hand as a postganglionic axon and supplying the smooth muscle or the skeletal muscle, as the case may be. The postganglionic sympathetic supply now passes through the gray ramus communicans and enters the ventral root to reach the spinal nerve. They reach a cranial nerve through communicating branch and they are distributed through it. They pass through a vascular branch and are distributed through branches of the vessel as well, and they innervate the visceral organs. So that's how the postganglionic supply goes to the target organs. The distribution of sympathetic neurons is as per this: segmental level T1, T2, the head and neck; T3 and T4, thoracic viscera; T5 to T9 is the upper limbs; T10 to L2 is the lower limb; T6 to T12 is the upper abdominal viscera; L1, L2 is the lower abdominal viscera; and T1 to T12 overall is thoracic and abdominal viscera, which are innervated by the sympathetic distribution. Parasympathetic nervous system, also known as the craniosacral outflow, because they arise from the brain and as well as the spinal cord, and in the brain they arise from visceral efferent nuclei, leaving the cranium through the 3rd, 7th, 9th, and 10th cranial nerves, known as the cranial outflow. In the spinal cord, they arise from the lateral gray columns of the 2nd, 3rd, and 4th spinal segment, and that's called the sacral outflow. In the preganglionic fibers, they are extremely long and reach right up to the viscera of supply. These ganglia are called the terminal ganglia. They're right on the target organs and are situated mostly on the viscera. Therefore, the postganglionic fibers of this system, the parasympathetic system, is pretty short. Cranial outflow now is carried, as I said, by the 3rd, 7th, 9th, and 10th cranial nerves. They terminate in the ciliary, the pterygopalatine, the submandibular, the optic, and the peripheral ganglia. The postganglionic fibers, on the other hand, innervate the organs of the head, neck, and face, abdomen. The sacral outflow is the preganglionic fibers carried by the pelvic splanchnic nerves to the peripheral ganglia in the pelvis, and the postganglionic fibers then innervate the organs of the lower abdomen and the pelvis. Now we come to the neurotransmitters. So we've seen the entire network of the ANS so far. What about the neurotransmitters? So there are two main ones, acetylcholine and norepinephrine. All the preganglionic ones release acetylcholine. All the postganglionic ones release norepinephrine, except, and that's very important to realize, except the ones who supply the sweat glands, the erector pili muscles, which release acetylcholine on the other hand. The postganglionic fibers, mind you, release acetylcholine. So the points to note are the preganglionic acetylcholine, all of the postganglionic epinephrine, except the sweat and the erector pili muscles. The postganglionic, on the other hand, secrete acetylcholine only. The adrenal medulla is a unique exception in the body where it is supplied by the preganglionic fiber of the sympathetic nervous system. So that's again in a graphical depiction. You have the preganglionic fiber with acetylcholine, epinephrine going through the postganglionic one, except for where it goes to the erector pili and the sweat glands. And as I said, the adrenal gland is an exception to the rule. This is what is described on a graphical format. The physiology of the autonomic nervous system. Now, on the left-hand side, you will have the pupil and the organs. In the middle of the chart, you will have the sympathetic supply, what it does to the organ. On the right-hand side of the chart, you have the parasympathetic supply and what it does to the organ. If you see as a whole, most of these are absolutely doing paradoxical functions to each other. For example, the pupil, the sympathetic will cause pupillar dilatation and the parasympathetic will cause constriction. So, mydriasis is sympathetic, meiosis is parasympathetic. Similarly, the heart, a positive chronotropic effect, a positive inotropic effect through sympathetic, and a negative chronotropic and negative inotropic effect through the parasympathetic. So, the easiest way of remembering this is, you remember one side of this table and the opposite becomes the other half of the autonomic nervous system. So, you can remember maybe the sympathetic supply, what does it do to the every organ, and opposite automatically becomes the parasympathetic supply. Now we come to the pathology. So far we studied the physiological aspect of the entire autonomic nervous system. What is dysautonomia, where the entire process becomes dysregulated? So dysautonomic disorders may result from pathology either in the central nervous system or the peripheral nervous system. Signs and symptoms result from interruptions of the afferent limb, the CNS processing centers, efferent limb of reflex are controlling the autonomic responses. And the site of reflex interruption is usually established by the clinical context from where the autonomic dysnomia arises, combined by judicious use of ANS testing and neuroimaging. Clinical manifestations can arise from loss of function, overactivity, and dysregulation of the autonomic centers. When do we consider all of this? When there is unexplained orthostatic hypotension, syncope, sleep dysfunction, altered sweating, impotency, constipation or other GI symptoms, and bladder dysfunctions, all of which can point towards a patient with a autonomic dysregulation. How do we approach a patient of autonomic disorders? So, as the art of clinical medicine goes, the first aspect is history taking. So, review of the medicines they may be taking, because most of the medicines the patient may be upon may affect the ANS. Underlying cause for the symptom like diabetes, Parkinson's disease can cause it. Specific underlying mechanism like cardiac pump failure, reduced intravascular volume may also cause it. Look into those aspects. Physical examination includes measurement of blood pressure in a supine and standing posture. Neurological examinations include mental status, neurodegenerative disorders like a Lewy body, dementia, accompanied by significant dysautonomia can be seen. Cranial nerves examination, motor tones, motor strength, and sensations for polyneuropathies, all of these can be ascertained. Autonomic testings are the one which help in document and exactly localize where the problem rises, and that's done after a good history and a physical examination. Cardiovascular reflexes such as a postural hypostatic hypotension, which is defined of a systolic drop of more than equal to 20 millimeters of mercury and a diastolic drop of more than equal to 10 millimeters of mercury. Blood pressure responses to pressure stimuli, which basically includes ask the patient for some mental arrhythmic, sustained hand grip, exposure to a cold cause can cause rise in the pressure. A less than 10 millimeter rise of diastolic is abnormal and can point to an autonomic dysfunction. Heart rate with variability in the deep breath is seen by reflexes via the vagus nerve. Normally changes of posture from lying to standing followed by immediate increase in the heart rate and then a relative bradycardia with respirations, heart rate variations, sinus arrhythmias can also be seen. In patients with parasympathetic lesions which are above, the responses will be reduced and abolished will be seen in diabetics and other autonomic neuropathies. Normally, the lower limit of heart rate variability with deep breathing is 15 to 20 breaths per minute in less than 20 years of age group of people. 5 to 8 beats per minute of variability in 60 years and above individuals. What's a Valsalva maneuver? We are all aware of this maneuver. The response is to assess the integrity of the baroreflex control of heart rate, which is parasympathetic, and blood pressure, which comes under sympathetic control. What's the principle? In normal circumstances, increase in blood pressure at the carotid bulb triggers a reduction in the heart rate. So, rise in the pressure, decrease in the heart rate because of increased vagal tone, and a decrease in the pressure can conversely cause a rise in the heart rate, a reduced vagal tone. What's the procedure? A Valsalva is tested in a supine posture. The subject is exhaling against a closed glottis for 15 seconds and while measuring the blood pressure and the heart rate simultaneously. So that's the Valsalva in a pictorial depiction.